Yeah, so good afternoon, everyone. So it's my pleasure to speak in front of you again. And my talk is about the PRP for the ED, so in advanced order illusions. So this is the outline of my presentations today. And to see why PRP might be needed, we need to look how the patient's expectation for the ED treatment have changed over time. So in the past, the treatments like the injections or the vacuum device were already considered successful, just like Brother Alexei already present. But later, the PDA5 inhibitors made it possible to achieve the more natural erections. However, the 40% of the patients still don't respond well to them. And today, the patients expect more. So they want a normal sex life and ultimately a complete cure. So in fact, when we ask what the success means, so most of the patients says that the cure rank the highest. So that's why the regenerative therapies, one of the regenerative therapies is the PRP, are now being explored as the promising alternative. So the PRP is derived from the patient's own whole blood after centrifugations, resulting in the plasma fractions that's rich in the platelets and also the growth factors. So these growth factors are believed to play a key role in the therapeutic effects of the PRP. So the use of the PRP offers several advantages. So it's easy to collect and prepare and contains the growth factors in physiological proportions and has very low immunogenicity and allowing it to closely mimic the body's natural healing process. And we know that according to both the European and also the American guidelines, the PRP injections should be used only within a clinical trial or the experimental setting. So overall, the current international guidelines do not recommend the use of the intracavernosal PRP beyond the investigational or the research purposes. But let's look at the current evidence of the PRP for the erectile dysfunctions. So the meta-analysis from the 4 RCTs found that the PRP led to the improvement of the about 4 points in the IIEF compared to the placebo after the 6 months. So when we apply the minimal clinically important difference or the MCID, defined as 2 or 5 point increase depending on the severity of the ED, so the patients treated with the PRP were 3 to 5 times more likely to achieve that improvement. So interestingly, the effect of the PRP appears to improve over time. So showing a better results at the longer follow-up, although at the 3 months mark the difference was not statistically significant. And it is also worth noting that across all our studies, the adverse events were minimal, suggesting that the PRP injections are generally safe and also well tolerated. And this is a short schematic of the PRP injections. So the PRP is injected intravenously and a tourniquet is applied about 20 minutes. And however, when we look at the 5 available RCT, the protocol is very varied. And there is varying amount of the PRP injections, the frequency of the treatment, and also the preparation of the device. And presented here are the 5 RCT I mentioned before. So these studies included the patients with the varying degree of the ED, of the severity, with only one focus specifically on the vasculogenic ED. So the PRP doses also varied, ranging from the 2.5 milliliters to 8 milliliters per corpus cavernosum. And different commercially prepared the PRP systems and also were used. And the treatment frequency was not consistent. And additionally, most studies performed 3 sessions over the 3 to 4 weeks, while one study conducted only 2 sessions. So these variations highlights the need for the standardized treatment protocol for the PRP injections. And in its current state, the use of the PRP still faces the unaddressed issues. So these include the heterogeneity of the PRP preparations and the challenges in defining the PRP dose and determining which the ED population may benefit from the PRP and the questions about the potential role in combination therapy instead. So here is a short summary of the available methods for the PRP preparations. So in those RCTs, the R-Track Angel and also the Magellan systems were used, and both of which produce a Buffy coat base of the PRP. And in the Buffy coat base method, the Buffy coat layer, which contains a platelet is retained and then producing a higher platelet concentrations along with the greater number of the leukocytes. But the Arthrex Angel systems even allows the adjustment to hematocrit levels such as the 2% and 7%, resulting in different platelet concentrations. But in contrast, there is also the plasma-based preparations that yields a lower platelet concentrations with the minimal leukocytes. And with the many commercially available of the PRP preparations, the next challenge is determining the right PRP dose. So in one case series involving 8 patients who received the PRP injection therapy, the levels of growth factors in the PRP did not differ between the ED and also the control groups. However, within each group, there was a high variability in growth factor levels. So if these growth factors vary, so the question becomes how do we actually define the correct of the PRP dose? And in this slide, we can see two different studies that look at the relationship between the various platelet growth factors and also the platelet concentrations. So the findings show that the platelet concentration has some correlations with certain growth factors, such as the TGF, beta 1, and also the EGF, suggesting that the platelet concentration might serve as a surrogate marker for the PRP dose. And currently, there is no study in the ED populations that address these dosing issues. So since the PRP is also used in other specialties, I showed this meta-analysis in patients with the musculoskeletal injuries, which found that the total platelet dose may have a slight impact on the outcomes. So in the knee osteoarthritis, another study suggested a threshold of the 4 to 5.5 billion platelets per injections for a better results. So however, this evidence is still weak, as many studies did not report a detailed PRP compositions, and the outcomes may vary between the patients. And the next question is whether certain types of the ED respond better to the PRP. So most of the available RCT included the patients with the mixed or the unspecified causes of the ED. So with only one study focusing specifically on the vasculogenic ED. So ideally, the future research should analyze whether the different ED etiologies show the different responses for the PRP therapy. And this slide shows the results from the one RCT that demonstrated a positive effect of the PRP on the vasculogenic ED patients. However, in patients with the moderate severity, there was no significant difference compared to the placebo at the longer follow-up. The study also found that the improvement was associated with the changes in the end diastolic velocity or EDV, but not in the peak systolic velocity or the PSV. In another study, even diabetic patients were shown to experience some benefit from the PRP treatment. However, as expected, the baseline, the HbA1c levels influenced the degree of the response to the therapy. And here we also present the interesting study involving 150 men with the vasculogenic ED who received a single PRP injection. So the results show that the patients with a smaller mean platelet volume, or the MPV, had the poorer outcomes after the PRP treatment, including the lower the IIEF-5 scores and the less improvement in the PSV. However, it was also observed that the patients with the larger MPV tend to have a lower baseline of the IIEF-5 scores. And in theory, the larger MPV indicates the platelets with more intracellular granules, which release higher amounts of the growth factors. So however, the increase of the MPV is also linked to the metabolic conditions such as the myocardial infarctions, and also diabetes. And therefore, a higher MPV might reflect the underlying comorbidities rather than showing the PRP activity. And lastly, should the PRP be used in combination with the other therapies instead? So this meta-analysis found that combining the PRP with the ESWT resulted in better outcomes compared to the ESWT alone. However, the evidence is somewhat questionable. So one study may have been affected by the selection bias, as the patients who received the ESWT alone had a lower baseline of the IIEF scores. The other two studies were conference abstract that had not undergone a peer review, so making the findings difficult to interpret with the confidence. So to summarize the current evidence, so the one challenge is that the existence of the PRP studies are highly heterogeneous in terms of the inclusion criteria, the doses, and also the administration of the methods. And overall, the PRP did show a positive trend in men with the mild to moderate ED with the minimal side of the effects. But however, many of the studies involve small sample sizes and also short follow-up durations, which limits the general visibility of their findings. And next, I would like to share our results in our center of the PRP trial at our hospital. So the study included the men with the orogenic ED who were assigned to receive either of combination of the PRP injections and also the daily tadalafil or the tadalafil on alone, the monotherapy. So we use the region lab, the PRP system, with a total of 3 sessions administered over 2 weeks. So the main outcomes we evaluated were changes in the IIEI-5, the erectile hardness score, and also the adverse effects. So here we show the process of the PRP preparations. So first, we draw the blood of 20 cc's from the patients. So we divide it into 2 tubes, 10 milliliters per tubes. So it's quite easy. So yeah, maybe you can also ask your nurse to do it. So the tube is already specifically with the region lab brand. And then after that, we invert the tube 3 until 5 times to dissolve the anticoagulant. And then after that, we do the centrifugation at the 3,500 RPM for the 5 minutes. And this is the result. But after this, we need to resuspend the sample by inverting the tube up to 20 times, so holding the tube tabs cap securely. So this is the final PRP product. So usually we can get about 12 cc's after we draw 20 cc's blood from the patients. So after that, we put the local anesthesia on the penis. We usually change the needle with the smallest needles to make sure that the pain is not getting strong. And then after that, we inject 5 until 6 milliliters per corpus. We can also apply the tourniquet on the base of the penis. So we inject at the 9 and also the 3 o'clock of the penis. So this trial is still ongoing, but so far we have observed that the PRP groups shows a greater increase in the IIF scores and a higher proportion of the patients achieving erectile hardness scores 3 at the 2-month follow-up, while no significant difference was seen during the first month. So we can see that the improvement, we have to wait more longer. So for the future directions, the research should be focused on identifying the optimal protocol and the most suitable patients group for the PRP therapy. So this can be achieved by the standardizing the PRP preparation methods, including the factors such as the injected volume, the platelet concentration, and also the injections protocol. So the future studies will also consider the patient characteristics, such as the ED severity or the specific etiologies, and include the larger samples to strengthen the evidence. So to summarize these presentations, studies on the PRP have shown the promising results, particularly in the terms of the safety and also the potential efficacy, and despite the use of the highly variable protocols. But however, the current guidelines still do not recommend the PRP beyond the experimental use. So even with the promising findings, because the larger and also the multi-institutional, the RCT are still needed. So I think, thank you very much for your attention.